today I am going to speak regarding Intra Aortic balloon pump, what it does and how it works. So it is very important in the cardiology, in the field of the cardiology. So the objective of this presentation is intended to increase your existing knowledge on the care and transport of patients receiving IVP therapy. So coming first to the history, the realization that coronary perfusion mainly occurs during diastole came in 1950. Before that, it was not known that the coronary perfusion occurs in diastole as the other circulation goes in systole. So aspiration of arterial blood during systole with reinfusion during diastole decreased cardiac work without compromising coronary perfusion. This was first pointed out by Harkins in 1960. So the intravascular volume displacement with latex balloons concept came in early 1960s. So coming to the history, Contraindications described augmentation of coronary blood flow by retardation of the arterial pressure pulse in animal models in 1952. In 1958, Harkins suggested the removal of some of the blood volume via the femoral artery during systole and replace it rapidly in diastole as a treatment for left ventricular failure, so called diastolic augmentation. So in the 1960s, Molopoulos and colleagues from the Cleveland Clinic developed an experimental prototype of an IVP whose inflation and deflation were timed in the cardiac cycle. So that comes first IVP. So in 1968, Contraindications reported improved systemic arterial pressure and urine output with the use of IVP in 2 patients with cardiogenic shock, and he was able to salvage 1 patient, and that patient was discharged to the home because of the high BP. So balloon catheters which were previously available were 15 French and needed just like the TAVI which is right now in the 15 French to be surgically grafted into the femoral arteries. But with the advancement in the technology, percutaneous IVP sizes varying from 8.5 to 9.5 French rather than 15 French were introduced in 1979, and shortly after this Bergman and colleagues described the first percutaneous insertion of IVP in that time. So the first pre-folded IVP was developed in 1986. So coming to the background of the intra aortic balloon pump, it is a mechanical device that is used to decrease myocardial oxygen demand while at the same time increasing the cardiac output. So there are 2 purposes. By increasing cardiac output, it also increases coronary blood flow and therefore myocardial oxygen delivery. It consists of a cylindrical balloon that sits in the aorta and counterpulsates. That is, it is actively deflates in the systole and that increases the forward flow by reducing afterload, and actively inflates during diastole, which increases blood flow to the coronary arteries. These actions have the combined result of decreasing myocardial oxygen demand and increasing myocardial oxygen supply as well. So coming to the basics, the cardiac cycle, we know the cardiac cycle is the base of the any heart disease. So the ventricles propel blood through the pulmonary systemic circulation as a result of ventricular contraction. Blood always flows from high pressure to the low pressure position. The cardiac cycle is divided into systole and diastole. Coming to the term preload. What is preload? Preload is defined as the amount of blood volume or pressure in the left ventricle at the end of the diastole, that is the resting phase of the heart. Factors which affect preload include the aortic insufficiency. If there is aortic insufficiency, the preload will increase. If the circulating blood volume is more, then the preload will increase. Mitral valve disease, especially the mitral stenosis, will decrease the preload, and some medications like vasoconstriction will increase the preload, and while the vasodilator will increase the preload. So coming to the afterload, afterload is the resistance that the heart must overcome in order to eject the blood volume from the left ventricle. Afterload can be affected by aortic valve stenosis, which will definitely increase the afterload. Arterial vasoconstriction will increase the afterload, and the vasodilators will decrease the afterload. Hypertension again will increase the afterload, and the peripheral arterial constriction will also increase the afterload. So the myocardial oxygen consumption has a linear relationship to systolic wall stress, intraventricular pressure, afterload, and diastolic volume and wall thickness. Increase in any of these like systolic wall stress or end diastolic volume or afterload will increase the myocardial oxygen consumption and naturally the myocardial oxygen requirement. So coming to the concept myocardial oxygen supply and demand, which is the basis of this IBP principle, working principle. So inflation of the IBP during diastole increases the pressure difference between the aorta and the left ventricle, the so-called diastolic pressure time index. The hemodynamic consequence is that this is an increase in the coronary blood flow and therefore myocardial oxygen supply. So myocardial oxygen demand is directly related to the area under the LV systolic pressure curve. The term tension time index, the balloon deflation during systole causes a reduction in the LV afterload, thereby decreasing the tension time index. Thus, the ratio of oxygen supply, that is the diastolic pressure time index, to oxygen demand, that is the tension time index, known as the endocardial viability ratio, should increase if the IBP is working optimally. This can be evidenced by a decrease in the coronary sinus lactate level. So this is the basic cardiac cycle. We know that there is a first if you start from the systole, there is a isomolemic contraction, then followed by ventricular ejection, and after that isomolemic relaxation starts, and then the ventricular filling by the atrial systole as well. So this is the cardiac cycle. This is the basis of the IBP functioning, whether ventricular systole and diastole. That way I will go later on. So if you see the arterial pressure wave, there is a systole, and the systole usually ends with a dicrotic notch in the pressure tracing, and then starts the diastole. So the principle of the IBP is also based on this. So in one cardiac cycle, there is a systole which is relatively shorter as compared to the diastole. If you see here that the coronary perfusion occurs mostly during the diastole, especially the left coronary system, it gets most of its blood in the diastole, and the right coronary artery also gets more blood during the diastole. So what happens in the left ventricular failure is there is an imbalance between the demand and the supply. Supply is decreased, that is the oxygen required, supply is decreased, and the demand is more. So our principle of the IBP is to increase the supply, that is the more oxygen to be supplied, and the decrease in the demand, that the decrease in the requirement for the oxygen. So the principle of the IBP, it is a flexible catheter, it is a balloon inserted into the femoral artery and passed into the descending aorta. Correct positioning is critical in order to avoid blocking of the subclavian, carotid or renal arteries, otherwise there will be problem. And when it is inflated to this full, it usually blocks only 85 to 95% of the aorta. Complete occlusion does not occur, otherwise it would damage the walls of the aorta, red blood cells and platelets. Coming to the hemodynamics, helium is rapidly pumped into and out of the balloon through the helium pump. When inflated, this balloon displaces the aorta, displaces the blood that is in the aorta. This is known as the counter pulsation. Why helium is used? It is used because it is a soluble gas and will not cause an embolus. Suppose if the balloon suddenly ruptures, and it won't cause the harm. This sudden inflation of the balloon moves blood superiorly and inferiorly to the balloon, and when the balloon is suddenly deflated, the pressure within the aorta drops quickly, which reduces the afterload. So inflation of the balloon occurs at the onset of the diastole. At that point, maximum aortic blood volume is available for displacement because the left ventricle has just finished contracting and is beginning to relax. The aortic wall is closed and the blood has had an opportunity to flow to the systemic circulation. The pressure wave that is created by the inflation forces the blood superiorly into the coronary artery, so there is a more perfusion to the heart, and blood is also forced inferiorly, increasing the perfusion to various vital organs like brain, kidneys and other tissues. So balloon remains inflated throughout the diastole. At the onset of the systole, the balloon is rapidly deflated. The sudden loss of aortic pressure causes the deflation and the reduces afterload. So the left ventricle does not have to generate as much pressure to achieve ejection since the blood has been forced from the aorta. The lower ejection pressure reduces the amount of work the heart has to be do to resulting in lower myocardial oxygen demand. So, in the background summary, there is a preload but slightly decreased, afterload which is decreased as a result of the IVP, the coronary flow which increases, and myocardial oxygen supply, myocardial oxygen demand decreases, and cardiac output is absolutely increased. So, there is a decrease in the aortic systolic pressure, there is an increase in the aortic diastolic pressure, there is a left ventricular systolic pressure is decreased, left ventricular end diastolic pressure is also decreased, cardiac output is increased, cardiac afterload is decreased, and the cardiac preload is decreased, left ventricular wall tension is decreased, left ventricular volume is decreased. So, and the coronary blood flow is increased, renal blood flow is the increase. All these are the physiological effects of the intra-aortic balloon pumping. So, what are the indications of use of IVP? First is the cardiogenic shock following acute myocardial infarction. This is a class 1 indication. Mechanical complications due to myocardial infarction like VSR and acute MR, this is also class 1 indication. Then the patient is going for high risk coronary interventions like those with unprotected left main disease, with severe LV dysfunction, severe heart failure, or left main stenting as a precaution, or absolutely when you are doing the Pump-Cce in case of acute MI with cardiogenic shock, and it is used also as a bridge to cardiac transplantation. Then other indications are cardiac failure after a cardiac surgical procedure, refractory unstable angina despite maximal medical management, some refractory ventricular arrhythmias which are not been controlled with the medications, support during non-cardiac surgery. Sometimes patient is going for non-cardiac surgery with patient with severe coronary artery disease or severe LV dysfunction. In those cases also decompensated AS before aortic valve replacement. So, these forms the various indications for use of IVP like high risk CABG surgery, then other surgeries, ventricular failure, patient with cardiogenic shock, patient with refractory angina as a complication, VSR, MI or MR after acute myocardial infarction, patients which are weaning from the cardiopulmonary bypass to get the help in getting out of the CPB, and as a cath lab support also. Use of the contraindications of use of aortic wall insufficiency, because this is called already AR is there, so this will cause more AR. So, this is absolute contraindication. Then the dissecting aortic aneurysm, which may cause the which may extend the aneurysm. So, these are the absolute contraindications. Then relative contraindications are limb ischemia and threatened limb viability, because that may interfere with the blood supply as well as it may cause trauma to the vessels wall. Descending aortic and peripheral vascular grafts, end stage patient is having end stage terminal disease, abdominal aortic aneurysm is also, you have to be very careful, and patient is having coagulopathy or contraindications for use of heparin. So, IVP during or after cardiac surgery, patients who have sustained ventricular damage, patient with LV dysfunction preoperatively and experience harmful additional ischemia during surgery, they should be put on IVP. Some patients which are having relatively normal cardiac function but having stunned myocardium, in those patients, as long as it takes time to recover the stunned myocardium, you can take the support of IVP. IVP is a bridge to cardiac transplantation. 15 to 30% of the end stage cardiomyopathy patients awaiting transplantation need mechanical support. This may decrease the need for more invasive LVAD supports. The IVP kit contains introducer needle to puncture, then the guide wire to go into the aorta, then the dilators so that the IVP balloon can go inside from the femoral side, then the sheath, you can do it with the sheath or as well as sheathless IVP balloon, then the gas tubing, the syringe, 3-way stopcock and arterial pressure tubing. So, various sizes of IVP are available depending on the patient's height, but most of the time it is 35 or 40 mm. And recently you have seen that in the paper there is a shortage of IVP all over the India because of the decrease in the supply, so which is causing problem in treatment. So, insertion techniques is percutaneous, you can do it by sheathless or you can use through the sheath, that is 7 French dilating 7.5 and then 9.5. Most commonly 8 French sheath is used, and sometimes surgical insertion by the femoral cut down, or in emergency sometimes if the femoral arteries are not it's reachable, then the transthoracic. Positioning of the IVP is very important, where the end of the balloon should be just distal to take off the left subclavian artery, because position should, otherwise there is a compromise in the flow to the hand. Position should be confirmed by fluoroscopy. If you are doing the cath lab, it's okay, then you can just see it under the fluoroscopy. Or if you are not done it in the fluoroscopy, you have done blindly in the ICU, then the chest X-ray is very important for after doing this. Monitoring, you can monitor checks X-ray, as I already said, immediately after the procedure. Then you have to give heparin to maintain an APTT between 50 to 60 seconds. Repeat chest X-ray whenever you are in doubt. And hemoglobin and platelet count should be monitored every day, because the platelet is known to go down. So this is the IVP tip. It should be in the second to third intercostal space. Then the IVP timing modes. First is the automatic, that tracks cardiac cycle, cardiac rhythm and adjusts automatically. Then the semi-automatic, that is the operator must adjust inflation and deflation time, and manual must adjust inflation and deflation, as well as you can set fixed rate. So timing of counter pulsation, that can be set by either based on the ECG or based on the blood pressure tracing of the patient. There is an unassisted systole, then there is a diastolic augmentation on the right side, and then assisted systole. And if you see, the assisted aortic end diastolic pressure is less than unassisted end diastolic pressure. This is a normal augmented wave. If you see, there is a first is the complete cardiac cycle, unassisted aortic end diastolic pressure represented by A, then the C is the unassisted systolic pressure, then the D is the diastolic augmentation, and then E is the reduced aortic and diastolic pressure after diastolic augmentation. These are the trigger and timing. Trigger event is based on the ECG, so it usually gets inflated with the diastolic diacrotic noise. This is the 1:1 IVP frequency. If you see that assisted systole followed by diastolic augmentation and then assisted end diastolic pressure. This is the 1:2 IVP frequency, that is IVP is getting inflated at every second beat, not on every beat. If you see, there is a difference between the unassisted systole pressure and the assisted systole pressure and diastolic augmentation as well as. And if you see, the assisted end diastolic pressure is less than unassisted end diastolic pressure. This is the same thing with the 1:3 IVP frequency, that is the IVP is getting inflated every third beat. There is no IVP inflation between 2 beats. When the 2 beats, then it is get inflated for the third beat. So how to check the waveform whether it is acceptable or not? First, change from 1:1 to 1:2 augmentation. Check the diacrotic notch. See if the augmentation start at that point. This should produce a sharp V. If you see, there is a red color sharp V at the inflation. Then again, you can check by other method also. See if the check if diastolic augmented wave is more than systolic wave. Then the diastolic augmented wave should be more than the systolic wave of the patient. Then again, a third thing is you can check by the confirm that if the end diastolic wave following the augmented wave is less than a non-augmented wave. Then systemic effects of various systemic effects of there is IVP, that is there is a neurological improvement, then there is a improvement in the respiratory function as well as more oxygenation to the blood, and there is a renal increase in the renal perfusion as well. And this is how it is seen. If you see on the IVP monitor, you see the systolic pressure, then the augmented pressure, which is 116, which is more than the systolic pressure. So and the ECG all. Yes. Factors affecting various factors which affect the diastolic augmentation are patient's hemodynamics, heart rate. If it is more, then there will be less diastolic augmentation. Stroke volume, if it is more, then the more diastolic augmentation. Mean arterial pressure, if it is more, then will be more diastolic augmentation. And if systemic vascular resistance is more, then the diastolic augmentation will be less. Then the intra-aortic balloon catheter IVP in sheath will give less augmentation as compared to the sheathless IVP. Then the if IVP is not unfolded, then it won't be able to give the diastolic augmentation. And of course the IVP position, as I already said, and kink in the IVP, that will not be able to give the proper diastolic augmentation or IVP leak. Then the timing, as I already said, intra-aortic balloon pump timing inflation is very important for diastolic augmentation, position of the IVP, augmentation control. So coming to the timing errors, early inflation, if suppose the inflation occurs early, then there is a waveform characteristic inflation of the IVP prior to diachrotic noise. So there is diastolic augmentation which encroaches onto the systole of the patient. What are the physiological effects? There is a potential premature closure of the aortic valve, potential increase in the LV and diastolic pressure, as well as pulmonary capillary wedge pressure, increased left ventricular wall stress or afterload, and there may be possibility of aortic regurgitation and increase in the oxygen demand. Inflation, if it occurs late, inflation of the IP markedly after closure of the aortic valve. So what will be the waveform characteristic? You can detect it by waveform characteristics. Inflation of the IB prior to diachrotic noise, absence of the sharp V just after the diachrotic noise. Then there will be suboptimal diastolic augmentation. So what will be the physiological effect? The suboptimal coronary artery perfusion because of the suboptimal diastolic augmentation. Then premature deflation of the IVP during the diastolic phase. What will be the waveform characteristics? The deflation of IVP seen as a sharp drop following diastolic augmentation. There will be suboptimal diastolic augmentation. Assisted end diastolic pressure may be equal or less than unassisted aortic end diastolic pressure, and the assisted systolic pressure may rise as compared to it should decrease. What will be the physiological effects? There will be suboptimal coronary perfusion, potential for retrograde coronary and carotid blood flow, which may cause angina, suboptimal afterload reduction, and increase in the myocardial oxygen demand. Then there is a late deflation of the IVP as the aortic valve is beginning to open. So what will be the waveform characteristics? Assisted aortic end diastolic pressure may be equal to or unassisted aortic end diastolic pressure. Rate of rise of assisted systole is prolonged. Then the diastolic augmentation may appear widened, very widened. What will be the physiological effects of late deflation? Afterload reduction is essentially absent. Increase in the myocardial oxygen consumption due to the left ventricle ejecting against a greater resistance and a prolonged isovolemic contraction phase. IVP may impede left ventricular ejection and increase in the afterload. So this is the normal balloon pressure waveforms. If you see, there is a peak inflation, that is the positive overshoot, then there is a plateau, full inflation of the IVP occurs, then the IVP deflation, and then there is a peak deflation, there is a negative overshoot, and then the return to the zero. So variation in the balloon pressure waveform, if bradycardia, the plateau will be long, if the tachycardia, it will be short. And this is based on the rhythm, there may be variation in the IVP inflation and waveform. Same with the hypertension and hypotension. And if there is a gas loss, so there will be a gradual decrease in the IVP pressure waveform. And if there is a kink in the catheter, there will be these peaks and overshoot all will go, and this will be like this, tracing will be like this. And if there is sustained inflation, it will be seen like this. Then coming to the clinical consideration, patient should be kept in bed and monitored for limb ischemia. Excised leg should be secured. Use of prophylactic antibiotic is not recommended in the IVP patient. Blood sample should not be obtained from the central lumen of IVP. What are the potential side effects and complications of IVP? There may be limb ischemia, bleeding at the insertion site, because there may be thrombocytopenia, immobility of the balloon catheter, there may be balloon leak, possibility of infection, sometimes aortic dissection and compartment syndrome. So how to assess the limb ischemia? Check distal pulses. You have to check it regularly and see the color, temperature and capillary refill. Monitor it very carefully, and it should be monitored properly and timely based. So monitor differential of the two temperature. What is the prevention? Use smallest sheath or catheter size available for IBP. Evaluate for risk factors, suppose more in the female, diabetic and patients already having peripheral vascular disease. Select the limb with the best pulse possible. Then what were the treatment options if it occurs? Subcutaneous xylocaine injection for if there is just spasm. Change the insertion site to the opposite limb if required, and bypass the femoral artery if there is a blockage of the femoral artery because of the IBP. Then there is excessive bleeding from insertion site. What are the assessment? Observe anteriorly, posterior for bleeding, or there is a hematoma formation. Check the hemoglobin of the patient. Prevention: employ careful insertion technique, should be properly by experienced operator, and monitor anticoagulation therapy. Prevent catheter movement at the insertion site. Treatment: what is the treatment options? Apply the direct pressure at insertion site. You may have to remove the IVP, assuring the distal blood flows. Then the surgical repair of the insertion site if required. Thrombocytopenia assessment: assist platelet count daily. You have to persist the platelet count. Avoid excessive heparin administration. Replace platelet if needed, and if there is a platelet count goes down below a limit, then you may have to remove the IVP. Troubleshooting in during the ECG trigger may not be functioning properly. Check slave cable connection. Check patient's leads. Change ECG lead source. Autofill may fill. Check helium and refill. If required, the helium gas may not be there, then you have to refill it. Balloon may not augment cardiac output adequately. Check the balloon position again properly. Reposition balloon if required. Weaning of the IVP: the timing of weaning, patient should be stable for 24 to 48 hours. He is maintaining a proper blood pressure, proper oxygenation level, and there is a minimum requirement of the inotropic support. Decrease pump from 1:1 to 1:2 and 1:3. Decrease the augmentation slowly, and then monitor patient closely. Weaning should only be attended on order of a physician. Then IVP removal: discontinue heparin prior to the IVP removal. Check platelets and coagulation factor. Deflate the balloon, and then apply pressure above and below the IVP insertion site. Remove and alternate pressure to expel any clots. It is very important to remove any clots lodged at the site of puncture. Apply constant pressure to the insertion site for a minimum of 30 minutes. Check distal pulses regularly. So what are the trials shows? The IVP shock trial showed in the 30-day mortality, no 30-day mortality benefit. Even after 12 months also there was no mortality benefit. RENU-C again found that the patient undergoing non-emergent coronary operation with stable hemodynamics profile and a left ventricular ejection fraction less than 35%. The pre-incision insertion of IVP does not result in a better outcome. Then Joe et al. Showed that in systemic review found that only low quality observational studies support IVP use post STEMI or for thrombolysis, not for PCI. There was no support from randomized studies. The randomized IVP study group trial found that patient randomized to aortic counterpulsation following revascularization of MI had significantly less reocclusion of the infarct related artery during follow-up. So despite all this, in our clinical practice and clinical experience, we have seen that many patients has been salvaged because of the IVP support, especially patient undergoing PAMI or post CABG. So it has got definite role, and what are the recommendation? The European guideline recommend it as a class 1C recommendation, while the American guidelines recommend it as a class 1B recommendation. And what are the recent advances? There is a proactive counterpulsation. What is it? Proactive counterpulsation is a new IVP system which incorporates two new and unique technologies: the wave timing algorithm and the ability to monitor the arterial pressure signal from a fiber optic source. Using the fiber optics IVP catheter. Wave is an acronym for the Wind-Kessel aortic wall equation, which automatically sets inflammation timing to occur precisely at the time of aortic valve closure. The wave algorithm converts the arterial pressure waveform to understand the patient's aortic flow in the cardiac cycle. Aortic valve closure occurs at the lowest point of the flow wave after peak flow occurs. Timing is set with each beat, so there is no variation from beat to beat. For the specific as it occurs, the result is highly accurate inflation timing, which is specific to the beat. For setting deflation timing during an arrhythmia, the IVP system automatically detects the irregular pattern and sets a conservative deflation to occur while assessing the balloon's performance in relation to the patient cardiac cycle. The combination of wave inflation timing and automatic R wave deflation timing results in real-time beat-to-beat timing, which corresponds to the changes in the patient's cardiac cycle. The result is an improvement in the hemodynamic effects of IVP during periods of arrhythmia also. So, very proper detection of arrhythmia and setting of the IVP inflation deflation according to the arrhythmia. The fiber optics IVP catheter incorporates fiber optic sensor technology into the tip of the IVP catheter. Once zeroed prior to insertion, it does not require any further maintenance such as re-zeroing or flush system. It is immune to electrical interference, patient movement or activities that interfere with the quality of arterial pressure signals such as transport.